Hello and welcome everybody. We're just going to wait for people to join us.
Good afternoon.
Hope you're having a lovely rain-free week. We're in South Wales and it's not raining, so that's a big bonus for us. I think that's most people joined. My name is Les Jones and I'm a seating assessor with CareFlex. I'm joined today by my colleague Rebecca Dunstall.
Good afternoon.
Rebecca's our clinical lead. We'll talk you through the presentation in a few seconds, but if I leave Rebecca off to load up her screen. Today's presentation is about how we use the information we've gathered during the assessment process to select the chair and the problem solved. It's a cliche that I often use, the devil's in the detail, and I'm sure we'll explain that as Rebecca works through a slide now. So is Rebecca ready?
Yeah, I'm ready.
Okay, and I shall see you in about 40 minutes or so. Thank you.
Thank you, Les. We're going to be looking at personalised seating provision. Today is a part one of a two-part series, which we will be continuing in April. We're starting with the clinical foundation today, how to analyse assessment findings, identify the dominant drivers and recognise when maybe a more personalised approach is indicated, where standard solutions may not be sufficient. In April then, as I said, part two, we'll build on this framework and focus on practical solution mapping, including the introduction of our new adaptive accessories. So today is about decision making first, because ultimately the quality of the solution depends on the quality of our reasoning. Before we get into the content, I just want to be clear about what today's session will cover, what it won't, and what to look forward to in April. This is part one, as I said, the focus is clinical reasoning that underpins personalised seating provision. By the end of the session, hopefully you'll feel more confident in analysing seating presentations beyond what is immediately visible to us, including distinguishing primary drivers from those secondary compensations, and also considering both the intrinsic and extrinsic contributors. We'll look at how to prioritise those findings in a structured way, using pelvic foundation as a guiding principle, while balancing all those other body segments as well and how they contribute to that. And importantly, while respecting the reality of compromise within complex care and within complex needs. A key part of today is also challenging assumptions. So we'll explore some common reasoning pitfalls that can affect our provision and our prioritisation, such as things like visibility bias and the assessment day illusion. Seating rarely fails because the chair is completely inappropriate. More often it fails because the provision doesn't sufficiently match to the person's real presentation and their daily context. So in other words, the chair may be right on paper, but still fails in real life. We can technically have this clinically correct prescription that still breaks down by lunchtime because we haven't fully accounted for things like fluctuating tone or fatigue, how their functions change throughout the day, or even things like their care routines. That's why today's focus is not just on assessment findings, but on how we interpret and prioritise them. Before we get into the framework itself, I just wanted to really pause and define what I mean by personalised seating provision, because it can mean different things to different people. For me, it's not simply about adding more support. It's not about making a setup more complex just for the sake of it. It's about matching provision to the individual's presentation and their goals. It's about considering the realities around them, their routine, their environment, the care context, their hobbies, their occupation. And it's about prioritising the dominant drivers of breakdown rather than reacting to the most visible features of it. And then balancing positioning, function and transfers and tolerance, because they don't always pull in the same direction. And one thing that we always talk about is accepting and feeling comfortable with compromise in real world provision. We can't always tick off every single box, especially within complex needs. And sometimes we do need this skill of being able to prioritise and being comfortable with the compromise to make sure that we get this consistent, compliant use. So when I talk about personalised seating today, I'm really talking about a structured clinical decision-making process, not just a product decision. And that's why we're focusing on part 1, on reasoning first. So this is a framework that can help to support you through that process. If we rely on what we see in the first few minutes, or what has always been done, we're much more likely to treat the visible problem rather than the dominant driver. So before we talk about solutions, which we'll obviously go into a lot more detail in April, we need to ground ourselves in a simple clinical reasoning framework, not to make the assessment process more complicated, but to make our decision making more explicit and more consistent and more matched to real life. So we're focusing on the first 3 steps of this framework today: defining the main problem or problems, identifying the dominant driver, and then prioritising what should be addressed first. And then part 2, we'll go on to steps 4, 5 and 6 to build on that into that practical solution mapping. So the key shift today really is from assessment as purely a data collection exercise to assessment as solid decision making. We're not just documenting posture, we are deciding what is driving the problem, what needs to be addressed first, and what compromises are acceptable for individual cases. Before we kind of move on to that framework, it's worth being honest about where seating provision often breaks down in practice. These are some of the most common barriers and challenges that we see. Importantly, they're not usually about a lack of effort. They're often about complexity not being fully anticipated or prioritised. So, for example, fluctuating tone. A setup may look appropriate at that one point in the day, but then becomes much less effective as tone changes in response to different stimuli. Fatigue is another area that maybe is often overlooked and underestimated, actually, regardless of how able or active somebody may seem at the assessment. We may not fully understand how quickly they fatigue, what their general strengths or weaknesses may lie, and what is a contributing factor to that, because gravity is unrelenting and it is difficult even for us. I'm sure you feel it at the end of the day yourselves, where gravity just takes that hold, and sadly gravity exaggerates asymmetries, so further compounds some of those challenges that we see. So what might be manageable in the morning may not be sustainable later on, for example, and that's where that 24-hour approach has to come into care planning, but that's a whole other webinar. We may not be factoring in things like behaviour or mood or feelings. They can easily be misread when they may actually be feedback about things like pain or discomfort or poor sit intolerance, especially if we haven't put that effort into understanding somebody's communication strategies, especially with somebody who may be non-verbal. The functional demands are obviously going to change across the day as well, depending on safe eating and drinking, personal care, the hobbies and occupation that we mentioned. The fatigue will impact different levels of alertness, their interactions with other people and the world around them, and how the environment plays into that as well. And then another thing we may not fully take into account is those care routines and the caregiver demands and the responsibilities that lay on them as well, especially if we do heavily rely on them to follow care plans. There could be a breakdown there in being able to implement things consistently, especially maybe in multi-user environments or where there's a high staff turnover, for example. So findings from the assessment, they may be noted and documented, but the key drivers are not prioritised, which means that that setup, that final solution that's put in place can end up addressing what is most visible rather than what is actually driving that breakdown. So I guess this slide is a really strong case for why clinical reasoning matters. And then we'll touch upon some of these ideas throughout the session anyway. The challenge is often not collecting the information, it's interpreting what matters most in the context of daily life on that individual. So step one, before solution thinking, we need a clear problem statement. If we define the problem or the challenges or the barriers too broadly, we end up with a vague provision. A person may present with multiple issues, but usually there is a dominant problem that is setting off the rest. The first step sounds simple, but it's where many of those assessments do drift, and sometimes drift in the wrong direction and loses that focus. We can describe posture in great detail. You know, we can be quite clinical with this. Somebody has a pelvic obliquity, which is higher on the right side. They have an element of trunk rotation happening. There's an element of rotation happening at the head. We have this lateral flexion happening in the spine, the scoliosis that's developing. But actually, we can still fail to define the actual problem. A useful problem statement will link what is observed, our assessment techniques and getting hands-on observed in that presentation, to the functional or the practical consequence. So what is breaking down, when and how. We can use our subjective assessment skills for this. When we look at just to clarify as well, we're not going to be going into detail and looking at assessment techniques today. That's something we've covered in past webinars, and something we go into detail practically and hands-on in our clinical study days. So if that is a skill set that you think needs some further learning or a refresher or something you want to work on a bit more, then just let us know, pop it in the Q&A, and I'm sure Kibi can share some information on those clinical study days. We simply just don't have the time to go through all those assessment techniques today. But we can use those skills to get to this point where we document those assessment findings. Looking at different things, and a big part of this would be pre-assessment as well, just to highlight, it's not just all about that one point of contact. It's about the planning stages, finding out this information, things like the contraindications, and really need to be mindful of how they communicate that I mentioned already before we get hands-on, knowing how somebody communicates pain, because I've worked with individuals who giggle or chuckle when they're in pain. So we need to really fully understand the communication strategies. A big part of this is history taking, this subjective part, where we're a bit of a postural detective, and this informs then the objective assessment, which we'll have a look at shortly. In practice, what this looks like is, I guess, really breaking down, stepping away from some of the clinical jargon. Maybe it's obviously important for our documentation, but actually to interpret that, asking the questions around what is actually happening, when does it happen, what is the impact, and what context. So a stronger problem statement would be including things like they are presenting with sliding in the chair. This happens most by lunchtime, after they've been sat in the chair for 4 hours. Where maybe they are starting to fatigue and they're asking to go back to bed. That's the impact. So they lack in that interaction because suddenly they're asking to go back to bed more than they should be, or frequently throughout the day, and spending more time away from communal environments or being able to engage in activities and so on. In the context, that means that it's increasing the care demands as well because of the movement and handling that's needed. So you can see that we're really breaking down actually what might first appear as a lean-in or a pelvic stability in the chair. In practice, we need that stronger problem statement. So it's not just poor posture and sitting with pelvic instability. It's progressive sliding, trunk collapse by the afternoon, which is reducing seated function and increasing repositioning during care. And then that can really help you to fully clinically reason where we go with the rest of our assessment and the provision. I am going to be challenging some assumptions today. I challenge myself with every complex case I see, because even after 15 years, it becomes very easy to assume things. I still picture this brilliant OT that I worked with when I was a newly qualified, kind of standing over my shoulder and asking, why do you think that? It keeps me honest, and is something that I want to pass on. In this world of complex needs, specifically, assumptions can quietly become facts, and we'll touch on this a bit more as we go through. Someone is non-verbal, so we assume they can't communicate, when the reality is we haven't worked out their communication style. We haven't considered that a particular sound or a movement is meaningful feedback. We may work with someone who's always spent afternoons in bed, so we assume that must be best, when actually it may have started as this short-term medical intervention years ago, and the routine has never been challenged since. We might see somebody who has always used leg rest elevation. They've always tucked their legs up, and assume that must be what's comfortable for them, when actually we may not have got hands-on. We've not checked the critical angles to confirm what their hips and knees and hamstrings can actually tolerate with leg rest elevation. So I want to be clear, this isn't blame. I've made the same assumptions, most of us have, and it's only when someone challenges us or quizzes our reasoning that we realise the power that we have to challenge assumptions, to break cycles, and ultimately do better. So today and going forward, I'm going to be that little voice on your shoulder, asking you, well, why? But let's dig a bit deeper and find out what the actual clinical reasoning is. My first assumption, and I guess myth busting, is that assessment day illusion. The person and the body that you assess in that first few minutes is not always the body that you're going to see later in the day. Many setups will look fine during a structured assessment, and then could potentially break down in real life because things like fatigue and activity and variable tone weren't fully accounted for during that time that we had together. So you may need to factor that into your planning as well. When I said about the subjective assessment, finding out when is a good time of day, when's a bad time of day. Do you need to see their habitual postures and their preferred postures? Do you need to limit the amount of moving and handling so that we're not impacting too greatly on tone, for example? Do we need certain caregivers present who maybe know them well to be able to carry out those effective assessments? So step 2, we are then looking at this as the interpretive step, I guess, where clinical reasoning becomes more than just that description. So we've got our assessment findings, we've dug a bit deeper, we've got that stronger problem statement. This next step then is the clinical reasoning becomes more than that description. So the same visible challenge, for example, trunk leaning that we mentioned, can be driven by pelvic instability, lower limb asymmetry, fatigue, tone, pain, all these things. And if we misidentify that main driver, then we're essentially treating the wrong thing. We like to say, we're plastering over things because we haven't got to the root cause of something. And that's where we really sharpen those skills. So 2 people can both present with leaning, but the driver may be completely different, which means that the seating provision needs to be completely different. And in real life, that setup just won't hold long term. So we're treating drivers, not just visible symptoms. There are certain risk factors that we can be aware of just to help kind of speed up that process. There are going to be things outside of this, of course, that we need to be mindful of because it is going to be individualised, but just to help you as a starting point to think about some of those risk factors in sitting that we might come across, breaking it down into intrinsic factors, some of the more postural or mechanical factors, and then even the extrinsic factors as well, especially within complex needs. Postural breakdown often happens, when these things interact as well. So it's not just going to be one thing, but we still need to get to that root cause and understand how they work with one another, how they battle against one another as well. If we assume that every issue is intrinsic, we may over-pathologize the person. Whereas if we assume that every issue is extrinsic and environmental, then we may over-adjust the setup and miss that underlying presentation. So it is a bit of a clinical skill in analysing the interaction between them all. And as I said, they're risk factors, so it's not always going to be evident in that moment as well. Sometimes it's all about being proactive and identifying where these risks may come into play and not necessarily be visible in that moment. So if you are working with someone, for example, who has experienced a neurological event and they are potentially now presenting with hypertonicity, so they have spasticity, for example, they may not have obvious contractures at that point, but that is a risk factor going forward, that if we don't manage their body shape and take them through range of movement and maybe signpost when needed to rehab medicine or spasticity clinics, we could then see ourselves with a much more complex presentation. So being proactive and not just, again, seeing what's visibly in front of us, but where that trajectory could lead as well. We can break this down even further. Where we then look at the individual components, the person, the chair, the environment, the caregiver, just to help us really analyse that information. And that's something we can support with as well. So as part of the seating assessment, where we would support you through that, we can talk about some of these things, even in the planning stages as well, where maybe you've done your postural assessment and you're coming up with those dominant drivers and the main problems and the challenges. You can share that with us, which means we can plan ahead for the seating assessment to make sure that we're maximising that time together. The objective assessment, as I mentioned, something we're not kind of focusing on today, but a skill in itself that leads us to this point in time where we've documented those assessment findings. And if it's an area of further learning that you do want to expand on, as I said, please do let us know. We'll let you know where our clinical study days are around the country and some of the webinars where we've touched upon this already. So we've done our subjective assessment, we've done our objective assessment, we've got the documentations, we're starting to understand the problem list in a bit more detail. We can then get hands-on to really then understand the dominant drivers of why somebody may be presenting that way. So then we may start documenting things like those postural challenges that we see, things like windsweeping deformity, scoliosis, increased thoracic kyphosis, which is important because it helps us understand the presentation. But this step 2 is all about then understanding what's driving those challenges, because, for example, if somebody presents visibly with a pelvic obliquity, and this is just a very kind of basic example, but they're presenting with a pelvic obliquity. If we don't understand that dominant driver or what the root cause is, it depends on whether we build up from the left or from the right. And that's how different that setup. To build up the base and the cushion of the chair from left to right is a significant change to the provision. So we really have to understand what's causing that pelvic obliquity, what's driving it, and then the next step then would be at prioritising and understanding what compromises may be, that battle between correcting and accommodating. So we begin to see this pattern recognition, we understand common presentations, but it's not just about identifying that postural challenge, we still need to ask what is driving it. So when we think about the pelvis, we hear terms like tilt, rotation, obliquity, stability, and so on, but then what's driving that? For the trunk, we're seeing trunk leaning, for example. Is it collapse because of weakness or low tone on one side? Is it because of high tone, they're being pulled into that position? Is it fatigue over time where gravity is just exaggerating that asymmetry? The lower limbs may be presenting with some wind sweeping or rotation happening. Are there differences in range from left to right? Are there discrepancies in length? Could it be external positioning within the chair? Because often a lot of issues that we see are actually the transfers into the chair, where that's, it could be a completely extrinsic external factor that's influencing how that pelvis is positioned within the chair. So we just really need to dig even deeper and understand what these causes are. In practice, what we might see, so our observation is that they slide in. So they're going into that posterior pelvic tilt, that sacral sit-in, possible intrinsic drivers for that. And again, without getting hands-on, it's just guesswork. So we need to understand about tone and range of movement and strength, and seeing actually how correctable their posture is, what their physical limitations are, how much body distortion has happened that sadly we can't change, or how much can we start correcting things, so we understand those possible intrinsic drivers. In some of these cases we may need to signpost for further support to understand actually what's happening. Possible extrinsic drivers to that sliding. It could be that the seat angles, the critical angles, aren't set up for the tolerance of the hip or knee range of movement. It could be that the cushion, especially within pressure care, for example, if a cushion is placed on top of a cushion, it could be creating that pelvic instability. As I mentioned, it could be the leg rest elevation. They just don't have the tolerance for that. So this is where then we start being, with that postural detecting, we're understanding, okay, they're sliding, they're going into that sacral sit-in, but why are they doing that? You might be the first person who's got hands-on. That's a very powerful place to be, to start actually understanding why somebody presents the way they present, and breaking that cycle and seeking support and making changes to hopefully not only maintain what they have, but actually restore in some cases, because that's what we aim to do with postural care. It's not just about maintenance, but actually restoring that as well. My next Mythbuster is all about the pelvis. I'm sure you've all heard about the pelvis being the foundation, and yes, I teach this myself in our clinical study days, but somewhere along the way, that foundation has sometimes been treated like a rigid rule rather than a guiding principle. Because yes, we know that pelvic instability can absolutely drive secondary challenges, including trunk collapse. Yes, it can influence movement disorders and contribute to abnormal movement patterns, such as an extensor thrust. Yes, we know that a stable pelvic base plays a major role in functional movement, because that proximal stability is what facilitates distal control. And all of that is true. But the pelvis is not always the dominant driver. So sometimes the pelvis is the symptom and part of a wider cycle that is already in motion. The dominant driver, for example, may be pain. If somebody is presenting with pelvic rotation and obliquity, it might be that they are opening up the hip angle because for pain relief, maybe they have an undiagnosed hip subluxation, for example, and that's the only way they have relief from that. It could be mood, distress, or a behavioural state, because we know that excitement and anxiety and agitation can influence tone. It may be overnight positioning. So if someone is persistently sleeping in a windswept pattern, then the lower limbs may be then disrupting that pelvic alignment during the day. So yes, pelvis first is an important principle, but we still have to investigate what is actually driving the presentation in front of us. And then from there, understanding what compromises we are willing to take. So it's not always about getting the pelvis back to neutral and correcting back to neutral and getting everything aligned, if then we see that being a detriment on head position, for example. But we'll cover that in a lot more detail in part 2. So we need to invest in our assessment process, and that's where we start to see that paying off, because it leads to a more effective prescription that's better targeted to that driver. And it's often actually a less complex solution than we might have had if we just reacted to the visible posture. So not only does it improve quality of life for the person, but it can actually reduce the intensity of our interventions as well as needed from us, which in practice supports our caseloads and more balanced working practices. This links to another common assumption in seating assessment, something that we call visibility bias. In seating, the first thing we notice is often the thing we want to fix first. That's completely human. We're all drawn to what is most obvious, but the most visible postural challenge is not always the primary problem. So, for example, going back to this trunk leaning, if somebody presents with leaning in the chair, we naturally focus on the trunk. But the most visible problem might not be the primary problem, as I said. So what we see first may actually be the secondary presentation, or something that's developed over time, or a compensatory position, or the end result of another driver. For example, like we just said about the pelvis. So, I mean, sometimes it is a trunk problem, but again, we don't know that unless we challenge and analyse our assessment findings and get to the root cause, get hands-on and understand what's happening. So that's why I said we always need to find out primary and secondary factors that may lead to that presentation. So that takes us on to step 3. So once we have defined the main problem, we've analysed the likely drivers, we can then move on to step 3, where we prioritise and understand what we may need to address, what we should address first, and hopefully, being able to check off most of that list, if not all, if we can work through it in a strategic way. So this is where clinical reasoning becomes decision making. In complex seating, we're rarely dealing with one issue in isolation. We're usually looking at this cluster of interacting factors, and if we try to address everything at once, well, we often end up addressing nothing well. So the first stage, we can ask ourselves some of these important questions. What is the dominant driver of the breakdown? So not what is just most visible, and not necessarily what is most dramatic either, but what is actually driving that pattern to persist or worsen, being proactive. Where do we see this presentation going long term if we don't intervene and break that cycle? Second, what do we stabilise first to make the other support effective? There tends to be a sequence to good provision. The foundation has to be stable. So bringing it back to the pelvis, we can still accommodate positioning away from neutral, but still have that stability. So that's why we always say, if we're not going to correct something for compromising, we still have to accommodate in that position to get that stability, to get that proprioceptive feedback. If the foundation isn't stable, the next layer of support may look correct for a period of time, but it won't hold in practice. So we have to take it back to that stability, and that could be different solutions. And again, we'll go into that into part 2, depending on where that driver is coming from, whether it's the pelvis, whether it's the lower limbs. And that's why I guess it's important that we understand what that dominant driver is. Third, what is non-negotiable for safety, for tolerance, for access, for compliance. This is a really important step, because sometimes the priority, especially I guess for us as clinicians, and it's strange me saying this as a physio, but the priority is not the posture that looks worse. It's the issue that is preventing things like safe eating and drinking, safe transfers into and out of the chair, being able to sit out for longer periods of times to protect their well-being, so they're not confined to the 4 walls of their bedroom. That maybe makes day-to-day care routines unworkable or unsustainable, so that they may actually be more important priorities than actually their positioning within the chair. And that's why we need that really strong subjective assessment to inform, daily life and understanding how the chair is going to be utilised, or any piece of equipment, how it's going to be utilised across that 24 hours and what we're actually aiming to achieve for this individual. For example, if we're working with a younger adult who is still able to access the community, still engaging in activities and occupation, who maybe posturally, we know we're still able to achieve some of those corrections from happening. We can protect their body shape as much as possible. Their seating provision and their priorities are going to be very different to an individual who maybe has sadly become confined to bed. Maybe they've been severely unwell, or sadly within palliative care. Their goals and objectives could be just to be able to sit out for an hour a day to be able to increase their well-being and mood and have that interaction. So if the priorities are different, the setup is going to look different, the choice of chair is going to look different, and the compromises are going to look different. So we need to understand what is non-negotiable for them, regardless of their postural presentation. We then need to ask what is primary and what is compensatory. That helps us understand those dominant drivers, because some presentations are the body's best attempt to cope, and in some cases we don't want to aggressively correct that either, because without understanding why they do it, we could be then overcompensating. So for example, if somebody does have this pelvic rotation and trunk rotation, over the years they've compensated by having an opposing rotation of the head, for example, to help with their focal point, to help with their environment. If we then go straight into aggressively correcting the pelvis back to midline, suddenly the head position is way off, and we could be affecting things like safe eating and drinking and communication. And is that a compromise too far? So understanding, you know, what's primary, what is safe to correct, or whether we actually need to accommodate that and accept some of those compensatory elements. And again, that's why this has to be personalised, and we can support you through that when you're working with someone. And then finally, leads on nicely to what I just said, but what can be a controlled compromise? And that's a big part of personalised provision. We're not always aiming for ideal alignment, and again, strange for a physio to say that, but we're not always aiming for ideal alignment in every segment, every body segment. We're aiming for the most effective, sustainable, usable setup in the real world. So step 3 is really about making your reasoning explicit. What am I addressing first? Why am I addressing it first? And what am I deliberately not prioritising yet? And then that makes that plan a strong care plan, which you can implement going forward and much more likely to work in practice. And that's how the assessment process becomes most effective, that leads into the most effective seated provision. Being comfortable with accepting that not every issue can be fully corrected, and not every issue should be tackled first or aggressively. Prioritisation means deciding what must change first to make that overall setup more workable. We do have these guiding key principles of seating the CareFlex, just to make things a bit more consistent and to help with filter some of those decisions, really. Because once we reach this stage, the challenge is rarely a lack of information. It's usually that we have multiple competing priorities, you know, posture, tolerance, function, well-being, the caregivers, long-term risk, all interacting at the same time. So we can use these principles to help us decide on, you know, prioritising what needs to be addressed, what can be a controlled compromise, and what success actually looks like in context of daily life for that individual. So instead of asking, you know, what looks best, we're asking what is most clinically important here and what is most likely to improve real world use. Again, we go into these concepts and these principles in a lot more detail in our clinical study days, you know, specifically looking at assessment techniques and how we find out this information to get the data that we need, which then leads us to this stage. But this is just another good tool to help you to explain the reasoning more clearly to colleagues and carers and individuals and services as well, because we can show that the decisions we make, especially if you're asking for funding, for example, you know, with clinical justifications, we can show that the decisions lead to outcomes that are structured, that are deliberate and based on clinical priorities and not just preference. And that's how we can maybe make it a bit more objective as well, while still being in the realms of personalised care, which is hard sometimes to be objective. So turning those 6 principles then into a practical tool for each challenge that we identify, you know, or the driver specifically that we identify, we can use some of these questions then to test our reasoning. It's always good, as I said, to have that person on your shoulder asking why and what and when, because it helps us then to prioritise, especially if we know in some cases where we're not going to achieve everything gold standard. It can help us focus on what is most important, what's most at risk, where are those risk factors, and what needs to be protected first, I guess. So what we can ask for each of those challenge, each of those drivers, which principles, I said, is most at risk, what do we need to protect, and then what interventions will support multiple principles at once. And again, that's where we can come in. If you are taking charge of your postural assessment, coming up with that main problem list, identifying the dominant drivers and sharing that with us, we can then try and come up with solutions together to support multiple principles all at once. Or we can help you to be realistic with some of those interventions as well, and actually what is achievable from a seating solution, but actually what might need to be achieved from other elements of postural care, not just seating, because it's only a part of that process. There are lots of different tasks and postures and positions and equipment that they use across that 24 hours, which will impact on how effective the chair is. So, for example, if the chair is used for 8 hours of the day, we've still got the nighttime positioning, which is believed where a lot of postural challenges start, and then they compound in and sit in. We have that interplay. If somebody is in a fetal position for 12 hours a night, how do we then expect them to extend out and maximise positioning within the chair? So you can share that with us. We can work together and collaborate on how we maximise the chair as part of that 24-hour approach. Once we start prioritising properly, compromise becomes unavoidable, and I just wanted you to be comfortable with that and accept that it's not necessarily a failure of the assessment. It's just a part of skilled clinical decision making. We're constantly balancing things like alignment and tolerance. We're trying to balance positioning control with transfer access. We're trying to balance stability with function. We're trying to balance, the precision, but also the usability and consistency with caregivers. We're trying to balance our clinical ideal and our clinical objectives with everyday reality and the person's preferences. Compromise isn't giving up, it's just prioritising deliberately. So the goal isn't a perfect looking setup in the sense of the product. It's actually, the goal is to set up a provision that is used consistently, reliably, but safely in real life without the risk of breakdown. And once we do have that perfect setup, it's obviously making sure that any risk factors are highlighted to the individual and the caregivers as well. And that would be part of the care plan, to make sure that if any changes do happen, they're targeted immediately and they know how to reach for that review process. Even if it's just even if you're discharging, there's a contact number or a process, so they know how to. And if I see a new red area, or if they start fatiguing very quickly, or if they start asking to go back to bed, I know I need to get back in touch with the prescriber to get that review process going. So it's a skill in itself, this art of compromise, and it's just being comfortable, as I said, with not chasing perfection, but making the best clinical decisions with the person's real world constraints. And that may mean accepting a controlled compromise. So that might be a nicer way to accept it, to improve that usability. So this is my final challenge assumption slide, and I framed it as a prioritisation pitfalls, because this is often where good assessments lose their impact. They're not beginner mistakes, they're common traps within complex practice, even when time is limited and the presentation is noisy. We can end up chasing symmetry before tolerance. We can treat trunk posture before properly analysing pelvic or lower limb drivers. We can build a setup that looks excellent in clinic but underperforms in real life. We can prioritise what is easiest to adjust rather than what is actually driving that breakdown. We can also miss extrinsic contributors, handling routine, setup, consistency, and unintentionally frame a system problem as a person problem. So this slide really is a reminder that the goal is not to correct everything, it's to prioritise deliberately, have that controlled compromise and protect what matters most first, to hold in the real world. And good prioritisation is not about correcting everything, it's about protecting. So postural care is all about protecting body shape, and sometimes that may mean maintenance. It may mean, sadly, as we know with some diagnoses, there is deterioration that happens. So it may be slowing down inevitabilities, but actually it's about restoring as well. And what does protection look like for that individual? What are our realistic outcomes, and how do we get to that point? So in terms of pitfalls, again, it's that fine balance, and it is a skill, and even after 15 years I'm still learning every day, and that's why it's always good to have that kind of person on your shoulder asking the whys, and hopefully we can be some of that support for you as well, and reach out and come and see us on our clinical study days. We have openings now as well, Les and I, to do more virtual bespoke training. If you've only got an hour or 2 hours with your team to really focus on, we can do that in the setup that we have for these webinars. So as I said, do get in touch. We want to support as much as possible, and share as much as possible, but also learn from you as well, because you are the ones who are out there on the front line, and seeing clinical practice fighting against daily routines and daily life as well. So that feedback is always helpful to us, to make sure that we bring that into our seating provision. And excitingly, when we look at part 2, you'll see how a lot of feedback has now driven some of these new adaptive accessories that we'll be showing you, and some of the tailored solutions that we do. Those of you who use CareFlex will know about our tailored solutions, where we're pretty unique because of being able to manufacture on site in sunny Devon. I don't know if it's sunny at the moment anywhere, mind. Yeah, but I think it's sunnier than South Wales. That we can really tailor that provision, and really work on our personalised seating approach, by working through some of these skills together and being able to clinically reason. So this slide here is really capturing at which point should we start questioning whether a standard configuration is likely to be sufficient. These indicators don't mean the standard provision is wrong, but they do suggest that the presentation of the individual may need a more personalised approach. So in other words, this is where clinical reasoning from part 1, those steps 1 to 3 we just looked at, starts to point us towards more tailored or bespoke decision making, and that's where we will pick up in part 2 in April. We've got a bit of a break in between part 1 and part 2, because in March we're focusing on continued learning, and you're probably aware that the HCPC are doing their CPD week at the start of the month, and we're just building on this to try and support you through things like reflective practice. So keep an eye out for that exciting webinar, because it will be a really useful tool in terms of how to put that CPD into your daily practice, but also how we bring in the element of this holistic approach to interventions and postural care interventions that we do. So we'll pick up then part 2 in April, and we'll take the indicators from today and work through that practical solution mapping. So just to reiterate then, part 1 was about recognising the threshold for this, and then part 2 was about what we do when we cross that threshold and how do we then tailor these seating provisions. So let's just quickly show how this clinical reasoning may look in practice with a case study. And again, what we're looking at here is applying steps 1 to 3 in practice. So we've got James, who is a 48-year-old gentleman who enjoys music and film. He has complex disabilities, including cerebral palsy, epilepsy, and severe learning disability, and requires full assistance in all areas of daily living. And I think it's really important to kind of consolidate the theory we've just covered to real life individuals, because context matters. It shapes what I guess, success looks like when we talk about postural care interventions. We're not only thinking about alignment, as I said, and posture and correction, we're thinking about the individual, we're thinking about comfort and daily life and consistency and ultimately quality of life. That's what we're here for, right? As clinicians, we're here to advocate and improve quality of life. That is the end goal. It's just how we get there through those clinical factors, clinical implications, and some of those drivers that we see. So let's have a look at James then and work through that personalised approach. So step one, having a look at defining the main problem. So at first glance, James presenting with some obvious severe challenges, recurrent sliding, that breakdown in positioning, the tolerance across the day. We could see pelvic asymmetry. We could see the trunk instability and the pelvic instability and the positioning of the lower limb. So that real difficulty maintaining midline. And visually, that seems pretty obvious when we kind of look at James and how he presents in front of us. If we simply list all of those things, that's just an observation. It's not a problem statement. So then we define the problem as progressive breakdown in positioning and sit intolerance across the day, resulting in reduced time seated and increased care burden. So James was asking to go back to bed a lot, which obviously has impact on his well-being as well. So we need to link that postural presentation to the real world impact. Then we need to identify the dominant drivers through our assessment skills, subjective, objective, getting hands-on, understanding why James may be presenting the way he is, because again, we can make a lot of assumptions from looking at James. We can make assumptions about his, I guess, the inabilities, the potential contractures, the body limitations that we might see in, and actually make assumptions of what the James isn't actually to achieve any midline positioning. He's not able to achieve critical angles for sitting because of how he's presenting in that position. And again, I'm not going to go into the before and after because this is just about step 1 to 3, but I just want to get you to start thinking about, what are we assuming those dominant drivers are, or do we actually need to get to the root cause and assess and understand what they are, because that's 2 very different presentations. Is it time of day variation? Is it fatigue related trunk collapse? Is it because of pelvic instability? Is it extrinsic factors because of how the chair has been set up? And then we started to really question ourselves and understand the why, the primary, the compensatory, to really know what we need to target. So at that stage, it's really important that we don't automatically assume primary problems. We use our skills as clinicians to understand and question and challenge and try and break some of those cycles. Visibility bias can creep in here. Again, we're often drawn to the trunk, drawn to the pelvis and the head, and making assumptions again about what may be a messenger rather than a dominant driver. I said about the extrinsic contributors as well. How is the chair being used? What is the knowledge base of the people using the chair? What do we expect them to be able to alter and change throughout the day? Is there a robust care plan that allows them to follow that across the 24 hours? And I guess then just empowering you to think about challenging some of those assumptions. So it can become evident sometimes that a position that somebody adopts became a habit from somewhere. So somewhere, someday, they saw James sitting in this position. That then got repeated the next day. It got repeated the next week, the next month, the next year, and nobody was asking, can this change? Can this be better? And that's where the power lies with us to break that cycle and get in and ask the whys and, okay, what is driving this and how do I get to the root cause of that? Which then leads us on to step 3, because again, especially within some of these complex presentations, we have all these competing factors. How do we understand? So we got the likely drivers. We can then start to prioritise things like that breakdown in pelvic stability and the positioning consistency. Because without that, any attempt to improve the trunk and the head position, for example, is less likely to hold throughout the day. We need to look at things like sit intolerance, because they mentioned about him fatiguing towards the end of the day. Is that repeatable day to day? Is the usability of the chair a non-negotiable? So is there a knowledge gap here? Do we need to look at training and making sure that everyone understands and is competent and confident with the care plan? Because if that setup cannot be tolerated, for example, things like leg rest elevation, or if back ankle recline isn't suitable, and we don't hand over that information, how do we then expect it to be successful long term? And that's where I'm going to stop for part one, because in part two, we're then going to look at the same reasoning going forward into the practical solutions mapping and how then those steps inform step 4, 5 and 6. I just wanted to touch upon, I mentioned a lot about caregivers and care settings and daily routines. This is a really important slide, this holistic approach. Person-centered care is of course the person at the centre, but we have this circle around them that informs really what they do day to day, especially in complex needs. So sometimes caregivers understanding the support network can be either a positive or a negative driver within that. So we do need to appreciate, because we need to make sure that they are on board and compliant as well. So it's quite a heavy slide for just a brief introduction, but I just wanted to highlight that holistic approach. So our transition then to part two. We focus today on part one, steps 1, 2 and 3, defining the problem, identifying the drivers and prioritising what to address. And then please do join us for part 2 in April, where we can apply that reasoning in practice and we'll get some of those solutions in place. And Les can take his turn to shine. We can run through some of those exciting adaptive accessories with you. So our key takeaways then for today. Personalised seating provision is a clinical reasoning process and not just a product decision. A technically correct setup can still fail if it's not matched to the person's real presentation, their routine, but also the context of daily life as well. Steps 1 to 3 matter. We can't just jump to steps 4, 5 and 6. We've got to define the main problem, identify the dominant drivers and prioritise what to address first. The most visible postural challenge is not always the primary problem. You know, remember that visibility bias. Good prioritisation balances pelvic foundations, function, tolerance transfers and real world usability. So again, some of those guiding principles, just make sure they don't become rigid law for you. It's not always about correcting and aggressively correcting things. It's about the art of compromise. When standard provision breaks down repeatedly in day-to-day use, this is a strong indicator that a personalised approach may be indicated. And then in part 2 in April, we'll focus on that practical application. And hopefully we are now back on screen. And just see if there are any questions. Okay, yeah, we have got some questions. So in regards to the assessments, do you have a template we could use to go and assess and gain all the information we were talking about before we have a specialist to visit with us? Yeah, we do. So when we do our clinical study days, this is obviously an important part. Sorry, I'm talking at an empty screen there. So obviously an important part of the day is the assessment process and the practical tools that are needed. We have a pro forma that we supply as part of that. It is obviously not a strict go and use it. It's more a pro forma than you can take from, depending on your service, depending on the service users. It might not all be relevant, but that's something though we can certainly look at sharing if you want to reach out to us, and we can happily share that pro forma. Just remember, you still need to tailor it. You might not need all the information. You might need more information depending on the user, but yeah, we do. We've got some other questions. How would you define comfort, and how would you suggest that is explored with a low awareness person unable to express that? I mean, comfort. Yeah, I mean, comfort is subjective, and that's why I said about it earlier. It is a difficult thing to quantify objectively. There are things you can do. I mean, we can use things like you know, VAS scales, visual analog scales and things. There are some good outcome measures out there, although they are qualitative. Sometimes in their method, they can still sometimes give a bit more objective data we can use. What I would say is, you know, coming from, I specialised in learning disabilities. That's all I've done. I have personal motivations for that with my sister, but also that's what I specialised in uni, and then when I qualified, I went straight into learning disabilities. And even in individuals where, as I said, they may be non-verbal, where communication strategies are not typical or obvious, there is always a method of communication that they are attempting to utilise. It's really important to understand the individual, but also the caregivers as well, people who know them well where possible. Because even if somebody is verbal, around 70% of our communication is non-verbal anyway. So that's a big chunk that we can utilise even with someone who maybe has intellectual disabilities or maybe has neurodivergence. There is some form of communication, whether that's a particular sign that they might use, a gesture, a noise, even a change in behaviour. Obviously, there are exceptions to this, but when we talk about behaviours that challenge, there tends to be a communication element to it. They are trying to communicate something. So a change in mood, a change in their behaviour or their awareness is a sign that they're potentially trying to communicate that, especially with comfort as well. If somebody's not comfortable in the chair, even if they're non-verbal, it's often pretty clear. Even on their assessment process, it is pretty clear if somebody is, because if we're uncomfortable, especially with individuals like with complex needs, potentially where they have a neurological impairment, we will see a physical change in their presentation and their tone. And so that itself can be an indication. If somebody's not relaxing in the chair, if they're still unstable in the chair, if we see a tightening of the muscles or the tone going up, that's in itself is an indication that they're potentially not stable or comfortable within the chair.
And just to add, it's really critical there that if there's a key carer, that the family is present, because they will pick up on that much more quickly than we would.
Yeah. But it is just that whole personalised approach and understanding how that person would communicate that. Is it a particular communication strategy, or is it a change in behaviour, or is it a change in their presentation? Because it can become, especially if you tune into that assessment process when you're trialling equipment, you will see a shift in their positioning within the chair if they suddenly feel comfortable within it. You'll see, that stability happen. Sometimes a dampening down of those abnormal movement patterns may be a sign that they're finally comfortable and getting that proprioceptive feedback that they like. But it is a bit of detective work to find out, to be able to define that comfort.
Any more questions? Have we got time?
I think this one, can drivers be anything that impacts on the seated position of an individual? Yeah, it can be anything. As I said, it could be intrinsic, extrinsic, even down to the product selection, the environment. I mean, a driver could be something as abstract as we've worked with individuals, in a care home, for example, in a communal setting where maybe a focal point at that time is the television, for example, but actually that individual has never watched TV, and for them their focal point is looking out the window. So they've been positioned within that communal environment with the TV or the fireplace as a focal point, or the activity, where actually for them they want to be looking that way. So that driver has created them to rotate within the chair just because of the environment. So that itself is quite an abstract driver, but we've seen it happen. Yeah. So yeah, anything that impacts extrinsic, intrinsic, that anything that impacts on that seating, and sometimes we do need to think outside of the box, because that in that situation we could be thinking quite complex. If somebody's really irritated within the chair, they're starting to lean, they're getting pressure care issues, getting that instability, we could think that's quite a complex challenge, but actually all we need to do is change the environment and suddenly their setup is less complex and quite standard in the provision, because it's not an intrinsic cause. So yeah, like a driver can be anything that impacts on that. I think that's all the questions.
I think we've run out of time.
Yeah, sorry, there's a lot of me talking today, isn't it? But same as usual.
Yeah, well, yes, some things never change. I'd like to say a big thank you to Rebecca. I just found that a really insightful presentation, more so than your normal insightful presentations. But it was great to have certain things reinforced and reminded of some of the key drivers of a seating assessment. It's stuff as a seating assessor I come across every week. So yeah, very informative presentation today.
I think we forget the power that we actually have to break these cycles and challenge those assumptions. So it's nice to be empowered sometimes to actually question, and not in a blame way, but in a, okay, what's the barrier here? What can I change? Has anything else been trialed? Do I know what that driver is? Rather than just making those assumptions. So yeah, and as I said, we'll kind of touch upon this and build upon it for part 2. Yeah.
We'll soon be in April. It's hard to believe how quick time is going, isn't it?
Yeah.
Well, I think that's us done for the day.
Yeah.
We look forward to seeing you again in April. Thank you for attending.
Yeah, keep an eye out for our March one. It's going to be quite a different webinar, so keep an eye out for that. I'm sure Kiwi will keep you all in up to date with it, but if you're not on the newsletter, then do sign up for that. And if anything we've mentioned about the clinical study days or the bespoke kind of virtual sessions, again, just reach out to us. And I know that Kiwi would have given you all the stuff in there.
Yeah, I was running ahead of myself. I was in April before we got.
Yeah, I know.
So time is flying.
Thanks very much for joining us.
Thank you.
Thank you. Bye.
Bye. Bye.